Hi all, this is Dr. Suchard with a short presentation about the use of glucagon as an antidote. Glucagon has a few potential therapeutic applications, but we're most interested here on its use in treating beta blocker toxicity. The objectives for this presentation are that when you're finished with the video and studying any related course materials, you should be able to describe glucagon's structure and mechanism of action, explain why glucagon is recognized as an antidote for beta blocker toxicity, and provide a dosing regimen when using glucagon for this indication. As you know, glucagon is an endogenous peptide hormone that is involved in glucose homeostasis. If glucose levels are high, the pancreatic beta islet cells detect this and release insulin to reduce the glucose levels. And on the other side of the feedback system, if glucose levels get too low, glucagon is released by the pancreatic alpha islet cells, stimulating glycogen breakdown and raising the serum glucose levels. And normally, there's a fine balance here, and the patient experiences neither hyper nor hypoglycemia. And now here's an interesting mnemonic device. The name glucagon is a portmanteau word, like how spork is a shortened combination of spoon plus fork. Glucagon is literally a glucose agonist. Currently, all pharmaceutical glucagon is synthesized through recombinant DNA technology to make a pure product, which has several therapeutic applications. Since glucagon is a glucose agonist, it can be used to treat hypoglycemia. Glucagon is also used for various gastrointestinal imaging and procedural indications. Those are glucagon's FDA-approved indications, but it's also used for helping to dislodge esophageal food bolus impactions. And this little animation shows an inadequately chewed piece of steak that got stuck in the esophagus, but glucagon reduces the esophageal smooth muscle tone, hopefully allowing it to pass down into the stomach. For what it's worth, this doesn't work very often, but since it can potentially work, the gastroenterologists always want you to try it before they'll come in for a stat consult to perform endoscopy. But we're here mostly to talk about glucagon's other non-FDA approved but generally recognized indication in treating severe cardiovascular drug toxicity, primarily from severe beta blocker overdose, but to a lesser extent also for calcium channel blocker toxicity. Since glucagon can raise serum glucose levels, it's pretty apparent that it can be used to treat hypoglycemia. This is mostly limited to use outside of the hospital, and the patient might be prescribed these emergency kits containing glucagon, sterile diluent, and a needle, syringe, and instructions. All in all, this doesn't seem nearly as convenient to use as, say, an EpiPen autoinjector, but it's definitely better than nothing if the patient is hypoglycemic, and it might be life-saving in some circumstances. However, giving IV dextrose is a lot more preferable when this option is available, like if the patient is in the emergency department or admitted to the hospital. IV dextrose is, of course, much faster since it directly puts sugar in the circulation rather than waiting for glycogenolysis to occur. Also, there are several medical conditions where glucagon may be less effective, either due to lack of glycogen stores or inability to split the glycogen into glucose, as with severe liver disease. Okay, so how does glucagon work? In this figure, we see that the dark blue beta-adrenergic receptors on cardiac myocytes are blocked by orange beta blockers. This decreases signaling to turn on adenylyl cyclase, which converts ATP to cyclic AMP. Without enough cyclic AMP, there can be a severe reduction in chronotropy, slow heart rate, and inotropy, contractile force of the heart, resulting in hypotension and bradycardia. But we see on the right side that the purple glucagon receptor is another G-protein-coupled receptor that shares the same cyclic AMP second messenger system as the beta-adrenergic receptors. Giving glucagon will stimulate adenylyl cyclase and hopefully overcome the beta blockade. In such a case, antidotal glucagon therapy is essentially saying, hey, if you've got beta blockers occupying the front door, I'll send the signal through the side door instead. For many therapeutic indications, the dose of glucagon is typically 1 milligram, but glucagon for beta blocker toxicity is given in high and atypical doses. The dosing quoted here is from Goldfrank's Toxicologic Emergencies and is based on data from case reports since controlled dosing studies have not been performed. The initial dose should be in the 50 micrograms per kilogram range, or about 3 to 5 milligrams in adults, given IV over 5 to 10 minutes. If this is ineffective, additional dosing up to 10 milligrams total may be given. Glucagon has a relatively short half-life, so repeat dosing may be necessary typically while monitoring for effect of other additional therapies. Glucagon repeat dosing may be either 3 to 5 milligrams IV as needed, or starting a continuous infusion at 2 to 5 milligrams per hour. The most prominent side effect of glucagon is inducing nausea and vomiting. Patients with tenuous mental status should probably be intubated before glucagon, lest they vomit and aspirate. Side note, when glucagon is used for esophageal food bolus impaction, this vomiting might dislodge the food, saving the gastroenterologist from needing to see the patient right away. Of course, glucagon can also raise blood sugar levels, but with severe cardiovascular drug toxicity, this is a minor concern. We also know that glucagon at non-antidotal doses can be associated with hypotension when used in non-emergent settings for GI procedures. But again, we wouldn't be using glucagon as an antidote if the patient wasn't already seriously ill, so we're already closely monitoring the blood pressure. Also, there are drug stocking and availability issues. The high doses used for antidotal therapy can easily deplete the ED or indeed the entire hospital pharmacy's supply of glucagon. This figure repeats the mechanism where glucagon treats beta blocker toxicity, but also includes how glucagon may also work for calcium channel blocker toxicity too. Increasing intracellular cyclic AMP, either through beta-adrenergic or glucagonergic stimulation, will augment calcium influx through the channels that are partially blocked by calcium channel blockers, and this can help overcome the impaired contractility. This figure also shows a potential role for inamrinone, a phosphodiesterase inhibitor, but that's not the topic of this glucagon-specific presentation and will be discussed elsewhere. When glucagon is used for either severe beta blocker or calcium channel blocker toxicity, it's typically a temporizing measure while waiting for other therapies such as high-dose insulin, discussed elsewhere, to be started and/or to show their hemodynamic effect. And that's all I have regarding glucagon as an antidote. I'll be seeing you around.